we are back for part 2 of our conversation with Dr. Poe. Dr. Poe, it's good to have you back on.
Thanks again for having me.
This is the sequel, and we really dug in on human connection, on healthcare and social media, even touched on telemedicine, a lot of digital pieces that weren't AI. We're going to talk about AI today in part 2. We also busted some doctor myths, so be sure to listen to part 1 of this conversation. But we ended with experience and how important it is for physicians, for example, to be able to actively listen during the patient experience, and also for the patient to be coming in unburdened to have that experience. As NRC Health, we have renewed our approach and our commitment to experience. We actually have a new chief experience officer. First time we've ever had a chief experience officer. Her name is Jennifer Barron, and you had her on your podcast, Kevin MD. She said something on that podcast, Dr. Poe, that was so interesting to me about experience. She said, we are all having experiences all the time. And it's true, right? In healthcare, we're having experiences, but we're having experiences all day, every day as people, as human beings. You and I are having experience as a conversation right now. But we know that healthcare experience is different. It matters so much. People come in with so much and high stakes of experience that they want to get out of it. From your unique perspective, what are the ingredients for a great patient experience?
So I think that there are several elements to a great patient experience. Number one, of course, is empathy. They want their doctors to listen to them in the exam room. They want their doctors to guide them through a dysfunctional healthcare system, because one of the things that we talked about earlier was that patients have so many questions when it comes to our healthcare system in terms of where to get information, even to access a physician, which hospital to go through. And there's that information asymmetry that patients have. We, in healthcare, we have all that information, patients don't. So I think that it's important that they're looking for some guidance in terms to navigate our healthcare system. And honestly, I think that patients are looking for time with doctors, right? Whenever patients go to the exam room or go to the hospital, it's often at the worst time of their lives. And when they want and seek that medical care, they want time with our healthcare system to take them out of those periods. So empathy, a guide, and time, those I think are the 3 main elements I think that would make a great patient experience.
That is probably the most unique answer I've ever heard on patient experience, and I've heard a lot of that over the years. I've been in this industry for 20 years. You don't often hear about empathy, or it's kind of folded in to some of the high touch things. You started with it. You don't often hear about guide, but yet consumers, before they become patients, we know in our research, they are looking for a guiding light, a force that will kind of get them through the maze. And then the time element, I mean, we have consumers who say, you know, my patient experience wasn't that great. We say, why? Your outcomes were good. You know, what you needed done was done. Yeah. You're back home and healthy now. You're talking to us. And they say, I didn't get enough time with my doctor. Okay. Do you feel like as an industry, we understand those priorities, or are we over here looking at something else, looking at, and I'm not besmirching quality and safety, but you can get locked up in a quality committee looking at metrics over here, or you can get locked up over here talking about financials. Are we getting it as an industry, or is this still a little bit of a mystery to us broadly?
So I think that there's more to an interaction with the healthcare system than simply a diagnosis and treatment and metrics, right? I think a lot of patients still want a relationship with their physician. I'm an internal medicine primary care doctor, and here in New Hampshire, our healthcare system recently had a contract dispute with a large insurer, and there was a risk for a lot of my patients that I would be out of network. And they were panicked when I was talking to them. They were worried that I could not be their doctor anymore. They were asking me questions: can I pay you in cash? Do you work at any other healthcare facility that where I would still be in network? And that reinforced my idea that patients go to and use our healthcare system for more than just a prescription and more than just a diagnostic test. They want, like we said, that guide. They want a relationship with someone who can share that journey with them.
I love your use of the word relationship too. That's something I've talked about a lot. And in fact, it's so important to us at NRC Health, this relationship and how it unfolds broadly. That doesn't start with the diagnosis, right? It starts many steps before. When you talked with Jennifer Barron, our CXO, you mentioned one of the challenges, maybe it's not a challenge, but one of the nuances of the relationship with patients and physicians is they may come into an experience with dueling goals First time I'd ever heard that, dueling goals. Can you talk about how those goals are dueling and how we might overcome that?
Yeah, so it's an expansion of what we talked about before, right? So patients, they want time, they want that empathy, and they want that guide like we talked about in the exam room. But sometimes the incentives for physicians are in tension with what patients want, because we have that fee-for-service system where a lot of physicians are paid by the number of patients that they see, the number of procedures that they do. There's always pressure from the electronic medical record to check boxes and make sure all the metrics are filled. And a lot of these things that physicians are incentivized for and physicians are pressured on goes in tension with what patients want. So that's why we talk about dueling goals, because sometimes in the exam room, the goals of what a patient wants and the goals of what a physician has to do are in conflict with one another.
It's so interesting they're in conflict too, because if you take those separate parties and you understand, of course, the physician point of view so well, but in our patient experience that we've done in NRC Health, we want a lot of the same things. You know, patients want to be listened to, they want things explained to them, they want that extra time, that empathy, and as a physician, you want to provide it. Are we doing any better as an industry, or do you think in the next few years we'll do any better at aligning to what is bringing us together versus what is sort of tearing us apart?
Yeah, so hopefully, I think that there should be changes in the reimbursement system, and I think we're going more towards what's called value-based care, which is away from a fee-for-service model. We talked in our previous episode about the impact of artificial intelligence and AI scribes that can take away some of the non-patient-facing work that physicians have to do, and that can rebuild some of that human connection and even give patients more time in the exam room with their doctor. So hopefully with some of the technological breakthroughs that I'm sure we're going to be talking about later, that can hopefully give patients that time and overcome some of the obstacles against that.
One more thing on obstacles, and then we will get into some of the really fun things, because we've alluded a little bit about some of these technology pieces. But, you know, you had a recent guest on your podcast on Kevin MD who brought up all the things that get in the way of a good experience, these sort of barriers or almost like boogeymen that sort of pop up and keep the patient from a great experience with the physician. You know, they cited the front desk, we cited some of the paperwork, some of the things you've talked about where the EMR is now who I'm making eye contact with instead of the patient. These can really intimidate patients, they can frustrate patients. I've had personally terrible experiences with front desk folks before I even see the doctor. So for our listeners, if they want to change that within their organization, is it something that we have to have more accountability? Is it measuring some of those areas of the experience that maybe we miss because we're so focused on the clinical piece? Is it culture? Is it something else entirely?
Yeah, so I think when it comes to the patient experience, and of course you guys at NRC know better than anyone else that it's the whole encompassing thing. So it's not just what happens in the exam room, it's right when they drive into the parking lot, when they and they talk to the front office staff, when it's registration. So these are all things that culminate into the ultimate patient experience. And you talked about some of the registration stuff, the front office staff. So I think that there are different ways that certainly we can approach that. We have to be careful that not everyone is comfortable with technology, and they may be comfortable going to the exam room or going to the clinic and filling out forms, pen and paper, and having someone guide them through that. But then there are some people who are comfortable with artificial intelligence and chatbots and maybe can fill out some of this paperwork at home before they come in and use some artificial intelligence tools to fill those out. So I think it's important for health systems to have multiple modalities and kind of meet patients where they are in terms of what they're most comfortable with, and that can maximize their experience based on what their own comfort level is.
Their own comfort level. And you know what's interesting about that is it may not totally be on age. You know, I was talking to a group of young folks. In fact, we had an intern, a summer intern at NRC Health who was in her 20s, and she talked about how she's totally comfortable with technology. A lot of those 18 to 34-year-olds, you know, the Gen Z folks coming up are, but they have fatigue with it. And in healthcare, sometimes they're like, hey, if I can do something that's not a screen, if I can talk to a human, that's sort of the innovative technology for them. So I love your point about comfort level, and it can really depend on the patient themselves versus a large demographic group. Let's go into AI, because this is probably something that hits everybody from age 2 to 92, to use the old phrase from the Christmas song. I mean, it's everywhere. And I was telling you beforehand that, you go to a lot of conferences and most of the speakers at least talk about AI at some point. You have such an expansive background and legacy in digital care, so I've got to ask about it. you had a guest on, I've listened to a lot of your podcasts, if that's not clear yet, who said, I prefer AI stand for augmented intelligence. I thought that was very interesting. We've heard that from some of our friends, some of our folks at NRC Health and the Governance Institute, but philosophically, what's your view? Do you think of AI as augmented intelligence? Do you think of it as something else? And maybe most importantly, what's its impact, true impact in the next couple of years?
So I think that we need to make the distinction between artificial and augmented intelligence. I think that there's a connotation with artificial intelligence that it's going to replace something, right?
Yes.
Replace doctors, whereas augmented intelligence, that it will be used in conjunction with physicians. So I think that's the distinction in my mind. So of course, I'm going to say AI would stand more for augmented intelligence because despite the rapid progress that AI has, and I think it's only been 2 to 3 years since ChatGPT first came into existence.
Right.
It's improving in an exponential basis. I think there were recent studies that I saw this week where they tested the diagnostic capabilities of some large language AI models, and they were on par, if not better, than physicians themselves. So I think that AI technology, when it comes to diagnoses and treatment options, I think that eventually it's going to be on par, if not better, eventually than physicians themselves. Now, that being said, what's the reason that we're here? We're here for the human connection. And I do think that in our healthcare system, it's more than just being accurate and getting the right diagnosis and treatment. I think patients want more than that. They want a relationship with a human physician, right? A relationship with AI. So I do think that people ask me all the time, is artificial intelligence going to replace doctors? And I say no, but I do think that the physicians who best utilize artificial intelligence is going to replace doctors who don't.
That is so interesting and so poignant too. And it almost makes it feel like the human physician, there could be a restoration of that almost. And even hearing that human physician sounds like a fantastic innovation, something that would draw me to a health system. So I think there's huge opportunities here. One possible shift that I want to ask you about specifically, because we've talked in the past about the patient who comes in with a stack of papers and they've already talked to Dr. Google. Dr. Google is everybody's primary care physician and they'll take a call or search any time of day. But now we've got a lot of people who are saying, and we're seeing this in our consumer research, that wow, a ChatGPT search is really quite well crafted. It's curated, gets me to my answer quicker than a Google search. So do you think, when we're just thinking about AI models and how fast they're advancing, do you think that that's an advantage, that people will be talking to ChatGPT, get a more sort of curated or crafted response than they would maybe sending out that shotgun Google search?
Yeah, so I think that right now, ChatGPT, and we're talking in February of 2025, I think that there's still problems with hallucinations. I wouldn't 100% rely on these large language models. But that being said, they're getting more accurate all the time. And we mentioned the studies that show that the diagnoses that they come up with is most of the time on par with what physicians can come up with. I'm a big fan of patients doing their own research. So whether they do it through Google or do it through AI or one of these large language models, I think that's fine. And then we certainly discuss some of the pros and cons. So I think that patients being empowered into their own healthcare and into their own conditions and doing their own research, and now they have more powerful tools to do that, I think it's going to certainly help our partnership going forward.
I want to ask you more about that, but it was funny you mentioned hallucinations. I was on a NRC Health webcast with Dr. Mike, who's also one of our influencers, along with you, Dr. Poe, and we had mentioned hallucinations on the webcast. We got a live audience with Q&A, and we said, it's where AI kind of gets things wrong and maybe gets them really wrong. And someone pointed out in the Q&A, AI can get things wrong and double down on it and say, no, this is true. So it kind of terrified both of us live that, wow, hallucinations can have a dark edge. We know there's some negativity. I think everyone listening has seen sort of that strange or odd sort of AI behavior, and it can kind of strike fear in our hearts. But I want to ask you about a positive example. Have you seen an example with AI where you think, or it's got the potential for technology to enhance that human connection in healthcare, that it would actually improve the bond between physician-patient instead of distract from it?
Yeah, so I think it's not so much with diagnosis and treatment, but it's kind of removing some of the non-clinical aspects of our care. And we talked in our previous episode about AI scribes,
Right.
where we can, where those scribes can listen to the conversation and create that note, and allows physicians to get off the screen and just kind of maintain that eye contact in the exam room. We talk about things like managing things like the inboxes, because that's one of the biggest things that physicians have to worry about. And if there's more bandwidth for physicians not to worry about things like messages and their inbox, and perhaps if AI can go through that and help with some of the, those patient messages, and that gives them more bandwidth where they can focus in the exam room. So again, I think right now, as we talk in early 2025, I think there's a lot of potential for AI to remove some of that non-clinical obstacles off physicians' plates, and that would give them the bandwidth to focus on that human connection in the exam room.
I love that. I think that that's so important. And I think all the patients, people listening, because we're all patients, would absolutely love that. I also think that Dr. Stephen Klasko, who co-wrote the book that this podcast is named after, Patient No Longer, inbox management, some of those things that are, you're just on the keyboard all the time. Yeah. He always talks about those are not things we went to medical school for. They just aren't as the physician, and sort of liberating the physician from that would be fantastic. We've talked about some heavy things in part 2, and even though this spans 2 parts, we've not yet done our speed round, which is always what I surprise our guests with. These are the lightest questions in terms of weight, and you could just answer them quickly, doctor, and I'll just rattle these off, because we like to compare these. We are a research company, so I'm going to ask you 4 or 5 speed round questions. You just give me your off-the-top answer. We are in New England, so I have to ask this one. Boston or New York?
I'm going to say Boston. I've been in Boston for 30 years now. I originally come from Canada, so I'm going to say Boston. So Celtics, Patriots.
And Dr. Mike, you might get an argument because he said New York, but he did say it while we were in New York. Morning person or night person?
I would say a morning person. I first started my blog back in the early 2000s, and that was when I was still going to clinic full time, and I would have to get up and do all these posts before I went to clinic. So I would wake up at 4 in the morning and make sure that all the posts were ready. So definitely for me, I'm a morning person.
I think our doctor answers to morning person very, very much skewed, almost 100%. We've had a few that say both because with your guys' schedules. Okay, next one, beach or mountains?
Oh, I am not an outdoors person. I know we're in New England. I'm going to have to say neither.
Neither, okay.
I'm going to say neither.
I don't think I've gotten neither on that one.
I'm going to have to say neither. I am neither a beach nor mountain person.
Okay, how about Coke or Pepsi?
I would have to say Pepsi.
Okay, I thought you might do neither on that one too. I've got neither on that one. Okay, last one. This seems to stump our audience. I'm not sure exactly why, but we're going to keep pushing that button. Favorite television show of all time?
My favorite television show of all time? I would have to say, and the reason this comes up, because there's that new show on HBO called The Pit with Noah Wyle, and then I think he, of course, was an individual ER, right?
Yeah,
it's such a seminal show. And I remember so many times, because that came out when I was an undergraduate at Boston University, and every Thursday night, we all grabbed together, TV in our dorm, we would watch ER, and then back then it wasn't a show like that at all, because it was just so intense. And then I don't know, I don't want to say that it prepared me for what was to come going forward, but it was just gave a little glimpse of what medicine potentially could be like. So I'm going to say ER, the original ER.
That is a great answer. We actually have recently studied this because we found that among consumers, television portrayals of doctors does slightly affect their expectations. It's not the main driver, but you think about doctors on TV and then versus reality, it's just fascinating to think about how that might affect consumer perceptions. I want to ask you a question next that I've asked every physician that's been on last season and this season of Patient No Longer. And you take as much time as you want to answer this because I think everyone listening is really interested in the future of the physician. What is the future of the doctor in America? When we think about America's doctors as a whole, you can think about however you want, but what future are we facing over the next 3 to 5 years?
Yeah, so I do think that there's going to be an evolution in terms of what the physician role is. So no longer is it going to be that paternalistic model, the Marcus Welby model, where it'll be whatever the physician says goes. I think that our role is going to develop more into a partnership with a patient. So in the exam room, the patient normally would be the captain of the ship, because it is their own body. And then, like we talked about earlier or a previous episode, that physicians are more like guides. Because when it comes to the majority of medical decisions, not to say all medical decisions, but the majority of medical decisions, we have several options. There's always a spectrum of options, more aggressive versus more conservative, right? Very rarely there's a right or wrong answer. And I think that it's important for patients to inject some of their individual values into that physician decision-making process. So I think the role of the physician going forward is going to be more of a partnership, more of a guide. We have patients rather than the paternalistic figure that physicians traditionally are thought of.
And I think that can be so powerful, not only for the reasons you state for physicians. In part one of this, you talked about how physicians need to find their own voice if they haven't and have their own narrative and really assert themselves into the process, because that sort of previous sort of control model or power structure model sort of leaves the power out of both hands. And so for the physician, it's reclaiming some of that power as a guide. And then for patients and consumers, that's exactly what they want their physician to be. They want a trusted source. They want a fellow human being, someone who knows them personally. You mentioned relationship that can guide them through this wilderness of healthcare. I'd be very excited for that future in the next 3 to 5 years. It was a very hopeful answer. I want to ask you one more thing before we get to our final question that we always ask. But specifically because I've got a physician in the room with me, I know there's a lot of organizations that say, we get it. We know that patients want a strong human connection with the physician. That bond is important. But we have so many hurdles that we jump through as an organization, so much sort of bureaucracy to tangle through. What's some advice that you give that listener who's saying, I want my physicians to be connected to my patients where I am right now? How do I go about doing a better job of that?
So I think there's a tension, and we talked about that dual,
Dueling goals, yes.
Yeah. So we talked earlier about the dueling goals, of course, right? Patients want that time. Physicians are pressured by no margin, no mission, right? So I think that there's that financial and volume-based incentive that physicians have. I think to those administrators and healthcare listeners who are listening to it, sometimes giving patients that time would mean less revenue, right? So they're going to have to make sometimes some of those sacrifices, sometimes addressing physician burnout so they could have more of that empathy for patients, more bandwidth for patients, and that human connection is going to require maybe longer appointment times, maybe seeing fewer patients, doing fewer procedures, and that's going to directly affect the margin of a medical institution. So I think those institutions that I talked to a lot of healthcare leaders as well, and they certainly recognize that fact and realize that in order to preserve in order to reduce physician burnout so they can better have that connection with patients, sometimes this is going to affect the bottom line.
I'm so glad you talked about the financial aspect of that. And I think there is organizations who are just pushing to make as much as they can. But there's a byproduct of that, a toxic byproduct of physicians who are burnt out, who are going to retire as early as possible, and talk about affecting the bottom line. So I like how you draw all that together. We've talked about a lot. We've talked about AI. We've covered so many pieces around busting physician myths and covering this topic. And I hope for future doctors that some of them are listening have already learned a lot from you, Dr. Poe. But I have to ask this question. I'll ask it physician specific. Day one, you get into an elevator. It's not a real tall building, but you've got someone else that scooches in, and they say to you, Dr. Poe, it's my first day as a physician practicing. Day one, you catch them on day one. What's a piece of advice you would give them as they're just starting out on their healthcare journey?
So I have a couple pieces, and the first is to take care of yourself, right? If you're on an airplane and God forbid the oxygen mask comes down, what's the instruction? You always put the oxygen mask on yourself before taking care of anyone else, right? So I think that metaphor applies to what we do in medicine. We need to take care of ourselves first, and that means prioritizing our wellness. It means sometimes setting boundaries. It means sometimes saying no. Sometimes we talk about things like the Hippocratic Oath, and sometimes I feel that is sometimes used against physicians because physicians are always going to put the patients ahead of themselves.
Right.
And sometimes healthcare leaders may take advantage of that because they know that we have that oath, that calling that we have, that we put the patients first. But that also gives a scenario sometimes where physicians are being taken advantage of.
Right.
And that directly, again, we talk about physician burnout. That's one of the reasons why 50+% of physicians are burnout and they're leaving medicine. We talked earlier about the financial aspects, right? And it'll cost something like $100,000 to replace a physician, but sometimes it's better, sometimes I think, wouldn't it be better just to use that money to kind of prioritize physician wellness? So that's my first piece of advice, really to take care of yourself, because if you can't take care of yourself, how can you expect to take care of patients, right?
Exactly.
I think the second piece of advice is that you have to know a little bit about the economics and the business of medicine, because gone are the days where, again, we don't have that model where we could only focus on that patient in the exam room and that's it. There are so many outside forces that influence not only our lives, but the care that we give for patients. So we do need to be aware of things like health policy and the business of medicine. And, we talk a lot about that on these shows as well, but it's important for physicians to kind of be aware of the external forces that can influence that. And I'm going to add a little third thing too, is be involved in leadership as well. So I think that when it comes to the changes in our healthcare systems, I do think physicians specifically, we need to lead, because if we don't make healthcare decisions ourselves, there's going to be other people who may not have our best interests at heart making decisions for us. So I think it's important for physicians on day one to really start looking into becoming physician leaders.
That's a powerful answer. That would have had to be a long elevator ride, but maybe in downtown Boston, they would have done it. And I think that physician getting out of that elevator with the ding would be a lot more prepared than when they started the ride. That is excellent advice. You've covered the gambit over this two-part conversation, Dr. Poe, everything from AI to the financial elements to empathy. These are really beautiful, hopeful things about the future of the patient experience. And honestly, it gives me a lot of hope too, and I think our listeners as well. So I really want to thank you for joining us today on Patient No Longer.
Perfect. Ryan, thank you so much for having me.
Wonderful. And that concludes this episode of Patient No Longer.